So I see a lot of people joining now. I think we should get started now in a minute or so. Got a great group of folks. I see a lot of our usual players, and I see a lot of guests who are not often with us. So welcome. I want to give a shout out. It's great that I see Zena joining us. Hi, Zena. We're always happy to see you. It's great to have you. And Michael Lang. Um, Great to see you joining us as well. It's been a while. One of our earliest investigators in the HIV Center, going back to the 1980s. Steve Marr and Robin Williams, a lot of great people. Thank you. Um, Teo or Stephen, anyone have any announcements they want to make at this point before we move on to introducing Dennis?
No, thank you, Bob.
Okay. Let me remind everyone, I can see it, just about everyone is on mute, but please make sure you're on mute during the presentation. And if you have questions at any point, put your name in the chat, and my colleague Steven Sukumaran will follow the queue and call on people in the order that they get their names in. So please keep that in mind, especially as we get closer to the end of the presentation. Just get your name there in the chat. Okay, well, welcome everyone. We hope everyone's being safe, and you and your loved ones and your family safe and as healthy and being as quote unquote sane as possible during this trying and challenging period for all of us. We're very pleased that Dr. Denis Nash is with us today and to share his expertise on stuff related to the COVID pandemic. That's great that he's doing this for us. Denis is an epidemiologist with over 20 years of experience and leadership in conducting epidemiological studies. His central issues have included infectious diseases, the field of public health surveillance, use of public health surveillance data to conduct rigorous assessments of programmatic effectiveness and impact of policies on health. He works extensively in both domestic and international settings, conducting large-scale, real-world epidemiological studies examining key outcomes among persons with HIV infections. So given that expertise, it's really great that he's using that expertise for this current pandemic. Dr. Nash is a distinguished professor of epidemiology at the CUNY School of Public Health. He has worked at the forefront of the emerging field of implementation science and is the founding executive director of CUNY's new Interdisciplinary Institute for Implementation Science and Population Health. He's published over 150 scientific articles. His research is primarily funded by NIH and CDC. And I'll just close with Denis is also, besides his roles at CUNY, he's the Associate Director of the Einstein Rockefeller CUNY Center for AIDS Research, their CFAR, and he's also Director of the Implementation Science and Health Outcomes Core here at our HIV Center. So thank you, Denis. Without further ado, I'm going to turn it over to you.
Thanks, Bob, and thanks for having me today. I am excited to talk about some of the work we've been doing at CUNY. I was, let's see if I can get my slides going here. But I just want to start by saying I was supposed to talk to you guys about this topic back in March before COVID-19 happened. And it was had to be rescheduled, but the topic was going to be focused on how a relatively recent commentary piece in AJPH about the importance of thinking about our metrics and how well aligned they are with the public health response that we have been mounting to end HIV epidemics. And the point was, I think that we needed to make a bit of a shift and a pivot from the status quo metrics that we have been using for years and years to something a little bit different that is more aligned with what we're trying to do around ending HIV epidemics, which is a much more rapid, focused, and targeted approach to the public health response. So I'll just stop there to say that sorry I didn't get a chance to talk to you more about this, but we had to make another pivot. And I want to
Dennis, I'm
start.
just going to jump in and say there's always a future time for us to revisit what you were going to talk about, because I think it still will be timely for a good while. So let's keep that in mind.
Okay. Thanks, Bob. But yeah, when all of this started, and maybe many of you were in the same boat as me, I mean, I was really kind of frustrated by the metrics that were being really thrown out there from all corners of society around the public health response to the COVID crisis. I mean, we're counting and paying close attention to trends in the number of new diagnoses when we knew that testing was really quite suboptimally low. And you know, when we would go from 25 cases to 50 cases, everyone would interpret it in 50 different ways. So I started thinking pretty early about you know, the public health response to the COVID crisis and the importance of thinking about disseminating common, really goal-aligned metrics. By goal-aligned, I mean you know, well-aligned with the public health response to the COVID crisis. And it really requires nimble and intensive public health action to minimize spread, as well as dealing with the really horrific socioeconomic and racial inequalities that we've seen in some of the outcomes. These early responses to crises often early on sometimes neglect the importance of timely dissemination of metrics, or what you could call epidemic intelligence, a well-chosen set of metrics aligned with the goals of the response. So I thought there are many goals, of course, to the public health response to the SARS-CoV-2 pandemic. But in thinking about metrics, I tried to take a step back and think about like what some of the key ones were from my standpoint. And goal one, I thought, was to, of course, mitigate, suppress, and control community transmission. And you know, since there's no vaccine, this really has to be through physical distancing and other non-pharmaceutical interventions. Goal two is about preventing or minimizing morbidity and mortality from COVID-19. And goal three is to protect the healthcare workforce and other essential workers from becoming infected. So I'll just talk about a few to give you a sense of some of the metrics that I've been thinking about really for this goal number one. And there are some parallels here, of course, to HIV. You know, it's about suppressing transmission, and it's about preventing morbidity and mortality. Those are two major goals too. But we needed a time updated proxy for incidence. The new diagnoses wasn't cutting it, right? This was just reflecting trends in testing and who was being targeted for testing and things like that, not necessarily incidence. So where this availability of testing is limited or changing rapidly, really need to think about other metrics that can serve as a proxy for incidence. And in this case, it seemed like the best proxy are COVID-related hospitalizations and deaths. And this can be used, this can be a reflection of what was happening with SARS-CoV-2 transmission about 5 to 15 days earlier. I just want to highlight here what was being seen in some of the New York City syndromic surveillance data. So this is like near real-time data on visits to the emergency departments on the top panel here for influenza-like illness and pneumonia. And on the bottom panel, showing the same trend for influenza-like illness and pneumonia admissions to the hospital from the emergency department. And you can see, you know, as early as March, early March, there was an uptick in all of this. And of course, this reflects what was going on with transmission, you know, days, maybe a week or so earlier than that. But it represents a very early signal in community transmission of SARS-CoV-2, and syndromic surveillance, I think, is a key tool for detecting and also monitoring what happens going forward. The DOH has been regularly updating information on hospitalizations, number of hospitalizations on a given day, and also deaths. And so you can see that these trends are both very sad, but lately becoming more and more encouraging that community transmission of SARS-CoV-2 is decreasing. The other thing that I think needs more attention in terms of metrics is tracking the number of active outbreaks in congregate settings like nursing homes, assisted living, and adult care facilities. These have been really hard hit. I'll come back to that in a minute too. But back to the syndromic surveillance data, this is the same data I showed you on the prior slide, stratified by age for emergency department visits on the left and hospital admissions on the right. And you can see how these kinds of metrics can really point to not only like the timing of when transmission was happening. Again, think about a lag here because these are hospitalizations, but also among who is most affected. And you can see the very striking dose response with age and hospital admissions on the right here, but also how these admissions have declined substantially in all age groups since. Goal number 2, examples of the kinds of metrics we might have here. This is another one put out by the city, showing the daily number of people that are in critical care across New York City health and hospitals, and showing the trend line, but also a target of where they want to be in order to begin to feel better about that the healthcare system is not being as overwhelmed as it might be, as it currently is by COVID-19. And this is an example of from Connecticut. New York is not doing this, but Connecticut started publishing number of cases and residents of nursing homes, and if you take a look at some of their tables, this has actually probably gotten worse since I did the calculation, but the case fatality rate in nursing home population in Connecticut was really quite high, 22%, and I'm sure it's gone up since, because you know, many cases were still in the process of being treated and recovering if they were lucky. But this is a really important population to track, and it's a really important population in terms of focus to prevent deaths and morbidity. And then goal number 3, protecting the healthcare workforce and other essential workers. This has really been a challenge here. If you, but it is really important that public health prioritize routine tracking of health screening and testing of all frontline workers. And the data that I've seen from CDC, trying to track this information nationally has been really difficult. Of all the cases of SARS-CoV-2 reported in the recent MMWR, only about 16% had information on healthcare worker status reported. They did a sub-analysis that showed among the 12 states that did report healthcare worker status for most of the cases, healthcare workers accounted for 11% of all the cases. And if you can look at the table over here on the right, you can also see that among healthcare workers, there are you know, hospitalizations, ICU admissions, and deaths happening. These among other essential workers are the folks who are keeping things together right now in many places around the country, and what we don't want to see are things like this where healthcare workers and other essential workers don't feel supported. We absolutely need to, at a minimum, monitor what's happening and have that guide some of the public health response and support for those groups. So using metrics to reopen society, to guide the reopening of society. This is the last slide I'll have on metrics, but we need to think, along with other criteria, how we can use metrics to guide this process that many jurisdictions have already entered into and that or will be entering into in the coming weeks and months. I think it's important, as we're seeing many places like New York doing, to specify a priori what are the thresholds for some of these key metrics and their trends that can guide decisions to reopen society, number one, or once society is reopened, what are the key metrics and thresholds to reimpose physical distancing measures should things begin to ramp up again. So what are the thresholds for lifting stay-at-home restrictions, for example, and what are the thresholds going to be for reinstituting physical distancing? We don't want to enter into a process of reopening society without some of these things specified a priori with the goals of the public health response, explicitly in mind and guiding the process. And I give some examples here of these kinds of statements I've heard from New York State regarding this reopening. So they're looking to see a 14-day decline in virus-related hospital deaths, or fewer than 5 a day, averaged over 3 days. Net hospitalizations for cases of COVID-19 must either show a continuous 14-day decline or total no more than 15 new hospitalizations a day on average over 3 days. So these are the kinds of things that I'm talking about, a priori metrics that to help guide reopening. I haven't heard yet this other thing about what are the metrics we're going to use to guide reinstituting physical distancing and other non-pharmaceutical interventions after things are reopening, but I think that's also important to specify. So moving on a little bit from some of the routine metrics, I also think that there is a need for observational cohort studies of COVID-19. The pandemic has really transformed life in so many ways across the US. The public health response and the medical response has been unprecedented. And there's certainly a need to investigate and characterize the evolving epidemiology of the pandemic caused by this novel pathogen. So including asking questions like who's most affected and at risk, what's the impact of implementing and relaxing different non-pharmaceutical interventions, not only on these SARS-CoV-2 outcomes, but also psychosocial outcomes like mental health and social support and interpersonal violence. In addition, there are some key epidemiologic questions, like among those with SARS-CoV-2 infection, what proportion are asymptomatic? Among those who have recovered from SARS-CoV-2 infection, is there short or long-term protection against reinfection and or development of severe COVID disease? There are studies needed that help to understand more about pathogen and host-related factors. And also there are still a lot of reliance on mathematical models to guide decisions, and there's a need to have more reliable input parameters for these things, and that can come from observational cohort studies. So this is what motivated our team at the CUNY Institute for Implementation Science and Population Health to launch a cohort study, an observational cohort study on this. We set up a website and a questionnaire on Qualtrics, where come and to our website and join the study. We launched this on March 28th at a time in the US where there were about 500,000 cases and about 700,000 deaths so far. We used internet-based methods to recruit people to the study. These are methods that Christian Grove and the Together 5000 team at the CUNY ISPH have pioneered over the last few years, and we pivoted here during the COVID pandemic to apply those to recruit a cohort of people that we would follow nationally for SARS-CoV-2 and other related outcomes. We recruited using ads on social media, showing a sample of those here on Facebook, Instagram, Scruff, and we used ad companies Fluent and Bytes Co. to assist with that as well. When we rolled out these ads and the possibility to enroll in the cohort, we had about 8,700 eligible respondents, and of those, about 7,000 actually completed the first questionnaire online. And we had to exclude a few because we didn't have complete contact information for follow-up. And in the end, we ended up enrolling about 7,000 people, or 81% of the initial group of eligible respondents. There was a slow rollout of some of the questions on essential workers, and so we did quickly after launch deploy a second version of the baseline questionnaire that added some questions on essential workers. And so we were able to administer that to about 5,400 of those 7,000 participants. So this cohort enrollment, this is showing the cohort enrollment over time in relation to the evolution of the death trend in COVID. And you can see that we were recruiting and enrolling people in this cohort during the upswing of the SARS COV2 pandemic in the US. In the end, we were able to recruit a geographically diverse cohort. We have participants from every US state, DC, Puerto Rico, and Guam enrolled. And if you compare the distribution of our geographic distribution of our cohort participants on the left to that of the epidemic spread as measured by new SARS-CoV-2 diagnoses, our cohort overlaps pretty well with what are some of the hotspots around the US. And just to give you an idea by state, the number of people that have been enrolled in each in our cohort from each state. Clearly, we have some states like California, New York, Texas, Florida, and Pennsylvania that have several hundred people enrolled. But pretty quickly, you can see how the sample number falls off as we get out to the right here for many other states. And so I just include this slide to make the point, that we're not really going to be able to do state-specific analyses. This is something we may be able to do it for a few states, but for the most part, this is meant to be a cohort that is a national one. So looking at some of the baseline characteristics of our cohort, you can see that we enrolled about 23% of our cohort is in an older age group, 60 years or over, 25% non-Hispanic, Black or Hispanic, and 16% were unemployed at the time of enrollment. So in addition to being a geographically diverse cohort, this is also a sociodemographically diverse cohort. 47% had income less than 50,000, 39% came from urban areas, and 50% fell into a category that we would call high risk for a severe COVID-19 outcome if they were to become infected with SARS-CoV-2. And that included things like age and also underlying health conditions and daily smoking that we use to put people into a category of risk. And importantly, not insignificant proportion of people aged 18 to 48 fall into this category, about 38%. 9% of our cohort were healthcare workers, and 5% of them were actually reported doing frontline healthcare work on COVID, so doing screening, diagnosis, and care for people with COVID or suspected COVID. And about 18% of our cohort are essential workers. So these would be people who are working in transportation, working in food delivery, or working in grocery stores, law enforcement, and other essential employment areas. So we also asked people about the uptake of non-pharmaceutical interventions and also symptoms. We saw a very high uptake of some non-pharmaceutical interventions, such as avoiding large groups, avoiding handshakes. And we also saw that these, for the most part, tended to increase with age. And looking at symptoms on the bottom of the table, about 20% of the cohort reported having some kind of COVID-like symptoms in the 2 weeks prior to cohort enrollment. And that proportion decreased with age, which is something we're looking into. Of those that reported symptoms, 60% fell into that high-risk category that I mentioned, being at high risk for severe COVID disease. 39% reported having seen a healthcare provider, and it was 46% of those at high risk and 12% reported being hospitalized, and 18% of those at high risk did so. And of the entire cohort, 5% reported that they were tested for SARS-CoV-2, and 8% reported that they tried to be tested but were not, and 2.7% reported an official COVID-19 diagnosis, and that was about 4.3% of the high-risk group. We also asked a few questions about mental health. Using the GAD-7 tool, we assessed anxiety symptoms, and about 36.8% of the cohort reported moderate or severe anxiety, or symptoms consistent with moderate or severe anxiety. And stratifying this by a couple of different factors, overall is the 36.8% on the left here. You can see how certain groups had much higher levels of moderate or severe anxiety than others in our cohort, including the healthcare workers, those who had symptoms or were tested or had a diagnosis or were hospitalized, of course, but also those that had a loss of income as a result of the pandemic, or those who needed care but couldn't access it. So that sort of describes what we've been learning from the baseline from the baseline enrollment of the Chasing COVID cohort. We've now started to move into the follow-up phase, and at month 1 we have begun to do these month 1 assessments and sending dried blood spot specimen kits to people's homes so that they could self-collect specimens and submit them back to us through the mail. Going forward, we're planning to follow the cohort monthly. You can see the timeline here. At month 3, we're going to do another round of specimen collection. We would like to target everybody, but we may only target those who are seronegative at the month 1 assessment, and we'll follow people out to 6 months. If it seems important to do another round of specimen collection, we'll try to do that. And I'll also say that we have we do not currently have funding to do the serology testing, so we're collecting the specimens. We've applied to NIH to get funding to test those specimens, and also to extend the follow-up of our cohort out to 2 years. We also deployed something many of you may have come across or even used, which is a COVID-19 symptom tracker app. Rather than try to get daily symptom updates from our cohort, many people have developed different apps, and this particular one has developed the ability for researchers to deploy in their cohort population and have the data merged into their cohort data, prospective cohort data going forward. So we've tried to deploy this symptom tracker to help us get information on symptoms in between these monthly follow-up visits. So on the left is covering some of the different areas that we measured at baseline in the baseline assessment, and then on the right here you can see what we're measuring during the month 1 follow-up assessment in this cohort. And so we've added some questions on trust in government to prioritize safety. We're adding the specimen collection for serology, food and housing security, depressive symptoms, social support, interpersonal violence, and questions on substance use, unhealthy drinking, and willingness to donate plasma to help others. This is the card that is going out to our sorry, I'm getting a message here from WebEx. This is the card that goes out with the specimen collection kit to give our participants instructions to collect the specimen. We actually did a small pilot in our cohort to see how well this worked, and this is a picture of the kit that went to the homes of a few of our participants, and they collected the specimens at home and submitted them through the mail, and reported that the process for the most part went smoothly. What about serology? So we like I mentioned, we don't have funding to do the serologic testing right now. It costs about $100 per specimen, and so until we do, we're going to be storing those specimens. And anyway, there's not really an acceptable serologic test that's validated for DBS that we're aware of yet, and so we'll wait until that happens. The one that we're looking at right now is the Remien serologic assay, which just was given emergency use authorization from FDA for IgG in serum and plasma, and it's currently being validated for dried blood spot. So what are some of the outcomes that we'll be looking at in the cohort when we can get the serologic testing? We'll be able to look at the incidence of SARS-CoV-2 infection, first among those who test positive at month 1, and we can use what we know about the pandemic as well as the timing of the testing to estimate when those individuals may have seroconverted. And we may even be able to use information based on symptoms that they've reported to us to pinpoint it even further, or the type of antibody that we detect on the test. And then there'll be those who test negative at month 1 but positive at month 3 when we're getting the second specimen, and we'll time the estimated time of seroconversion as the midpoint between those two tests, unless we can pinpoint them further based on their symptom reports. And we also will look at asymptomatic SARS-CoV-2 infection. So these will be people who have a positive serologic test at month 1 or month 3 with no documented report of COVID-like symptoms. And the best estimate, I think, of what we could get about the proportion asymptomatic will be if we restrict an analysis to those observed seroconverters between month 1 and month 3, and look at the proportion of those that reported any symptoms. So in this way, we'll try to estimate the proportion of SARS-CoV-2 infections that are asymptomatic, and add to several different estimates of this phenomenon that are out there. We also will look at the outcome of COVID disease. We can think about, we will define COVID disease as we have prior to month 1 in the baseline and prior to the month 1 follow-up assessment. And we can think of those as being confirmed if they have a serologic test. But it's also possible that some of our cohort participants might not have a serologic test, in which case we'll classify them as a possible case. And we can think of breaking this down according to severity based on whether or not they've reported being hospitalized for the symptoms. And the confirmed and possible incidence of COVID disease will also be tracked. This is important because we'll be able to look at the extent to which people that have SARS-CoV-2 antibodies are at a continued risk for development of severe COVID disease or not, relative to those who are seronegative. As I mentioned, we're also measuring some other key outcomes as part of this prospective follow-up. And then thinking about our exposures, we've been very interested in understanding the uptake of some of these non-pharmaceutical interventions that are part of the public health response. And so we're developing scores to categorize some of the different responses that people have had about washing hands, wearing gloves, wearing masks, avoiding gatherings, things like that, so that we can come up with kind of a summative score of their responses. We're also looking at what's going on in different states around NPI implementation. So we and others are keeping a sort of living database of the types and timing of different state level NPI strategies that have been implemented. And there are also even groups out there that are using certain indices, things called indices of stringency, that are being used to describe how stringent the NPI implementation is in a given country or in a given area, and we'll apply those indices to our data as well. We're also pulling in information on county level physical distancing. These data are, you may have seen, looking at changes in mobility using cell phone data. There's a group at Descartes Lab, and I think there are other groups, even Apple right now, that are publishing, using information from the GPS sensors of phones to kind of track and get a sense of how much movement there is in a given geographic area. For example, the maximum distance traveled during a given day, or in a group of people in a given zip code or a given county. And we'll also be looking at the reach and uptake of the expanded contact testing and contact tracing that is being rolled out as part of the next phase of the public health response. And this is something that is actively happening right now. As many of you know, it's hard to think about where we are in New York, but clearly it's happening in many places around the country as we speak. These are some of the recent mobility data. This is showing like the extent to which people are moving over the course of a single day. And so this was on the left here showing like where it was before a lot of these stay-at-home orders were issued, and how it really changed for a sustained period during March. The green line is New York. So you can see we're still very much down in a very not mobile mode right now, but this is not the case for many other areas, including California. It's really starting to creep up. So this is a index that we'll use in our data as well. We'll merge in. And this is just a map that shows what mobility looked like, that same data. Here, looking at counties on the left for March or for April 12th, there really was not that much in the way of movement going on. But on the right here, from May 1st, you can begin to see that different parts of the country are becoming more mobile. So some of our planned analyses, we want to try to understand the level of impact of NPI implementations on SARS-CoV-2 outcomes, including looking at the incidence of SARS-CoV-2 in our cohort using the serologic testing data, but also looking at the cumulative incidence of COVID deaths at the county level. And these are publicly available data that we'll be looking at for that. Among those with observed seroconversion, we will try to estimate the proportion that had asymptomatic infection. And among those with a serologic test at month 1, we'll try to estimate the incidence of any COVID-like illness between month 1 and month 6 by the serostatus at month 1. And we're going to be doing that in areas where there's active SARS-CoV-2 transmission. And this will hopefully give us a sense of the extent to which there may be some short-term and maybe longer-term, if we can follow the cohort longer, protection of antibodies against severe COVID disease. So I'll just wrap up with a couple of slides about the cohort, what it can't do, what it can do. There are some limitations, of course. We can't provide nationally representative estimates in our cohort. It's a convenient sample of people that have been enrolled into longitudinal follow-up. While it's geographically representative and sociodemographically diverse, it's not representative of the US population. We will likely underestimate hospitalizations and likely won't be able to capture any deaths among our participants. If participants do die, they're going to look like they've been lost to follow-up in our cohort, and we're probably not going to be able to say much more than that. And we can't conduct state or county specific analyses for most locations. And finally, the retention rate is not yet known. We're in the process of the month 1 follow-up, starting with our 7,000 participants. We've already gotten the month one follow-up assessments completed for about 2,000 of those, but it remains to be seen if how close we're going to get to retaining all 7,000 of those participants, and that's a really important metric for us. But the strengths of the cohort include that it was rapidly deployed during the upswing of this pandemic, and we are getting specimen collection done right before or right as physical distancing is being relaxed in many areas. It's a prospective study with the ability to observe seroconversion and development of disease. And we can potentially assess the impact of different strategies to opening up society, including looking at the uptake and impact of different strategies that are being implemented to help do this and guide this and manage it, including the expanded testing and contact tracing. So there's not much we can say now beyond what I've shown you. We've been able to enroll a geographically and sociodemographically diverse group of participants rapidly into longitudinal follow-up during the upswing of a pandemic. And we have a sense of what their baseline characteristics are. They're in areas where there's active and ongoing transmission and where they will be lifting restrictions on lifting stay-at-home restrictions in many instances soon. And a fair number of them are at high risk for a bad outcome should they become infected with SARS-CoV-2. But there's a lot remain to be learned that I think can inform the public health response to this current pandemic as well as future ones. So I'll just stop here, but I want to acknowledge this incredible team at the CUNY ISPH that really did unbelievable job of launching a cohort in the middle of a pandemic from the epicenter, one of the epicenters around the world of this SARS-CoV-2 pandemic, to get this off the ground in very short time and getting our first baseline paper published. I never thought anything like this could be done, and I'm incredibly proud of them, and I want to acknowledge them, very deeply for some very hard work during a very hard time, and also our Office of Sponsored Projects at CUNY for working closely with us to get our grant proposal submitted. Our IRB team for working closely with us to get things approved as quickly as could possibly be, and also our dean for supporting some of this work with part of the grant program that the CUNY School of Public Health has. So I'll stop there and take any questions.
Virtual applause. Thank you, Dennis. That was really pretty amazing. It's just so great for you to share this current and timely data. I'm really impressed with the nimbleness of you and your team to collect these data so quickly during this pandemic. These are really valuable data moving forward. I hope we can get a follow-up presentation from you down the road. So thank you again. And just before turning it over to Stephen to monitor our Q&A and discussion, your presentation actually reminded me in the beginning of an announcement that I meant to remind everyone earlier before we started, that this is National Nursing Week. And yesterday was National Nursing Recognition Day, which I think is particularly meaningful during this pandemic. So a big thank you to all the nurses and all the healthcare providers out there. I'm going to ask a very quick question before turning it over to Stephen. And sorry if I missed it, it may have been in there, but I'm just curious if with everything you're collecting, all the data you're collecting, are you also collecting any data around HIV status, HIV testing, or experience in HIV, just to see where there might be an intersection of your cohort and people affected or infected with HIV?
So far, the only thing we've collected around HIV is HIV status. So it was one of the conditions we asked, the pre-existing conditions we asked about to help determine if someone might be at high risk of a severe outcome. It's not to say that we couldn't, but that's the only HIV outcome we've asked about right now.
Okay, I guess I was wondering about even just HIV testing behavior to see how that's related to people seeking COVID testing, but just a thought.
Thanks.
Yeah. Okay, Stephen, over to you. You can monitor the rest of this discussion. Thanks.
Thanks, Bob, and thanks, Dennis, for a great presentation. We have quite a few comments congratulating your work. I'm not sure if you can see that, but I'll jump to the first question from Claude Mellons. For some of us in HIV who would love to include some COVID questions in our cohorts, Is there room to see more questions or collaborate?
Is there always room for collaboration and more questions? Yes. We are trying to keep the burden on our participants, as minimal as possible, and keep our questions focused on the overarching goals of the cohort study. But those goals are also pretty broad, so we're always open to hearing suggestions and collaborating with people. I will say that on this web page that I've listed here, we've been posting PDFs of our questionnaires. So anyone who wants to see what we're already asking, I didn't cover all of it, but right now we're administering a questionnaire at each follow-up visit that takes between 10 and 20 minutes to complete. So so we need to make sure that our only requirements are that we ask questions that are aligned with our goals, and that we don't overburden our participants.
Mm-hmm.
And we're very open to collaboration.
Great. We have a question from Rebecca Jaguar. Thanks so much for this. Sorry if I missed it, but how does the measurement of movement work? Given that New Yorkers tend to move smaller distances in general, given the proximity of businesses compared to more suburban or rural areas, how is that controlled for in the comparison?
So as I understand it, this is a group of mobile phone users that is tracked across the country. It's not everyone. I think it may be people who've agreed to download a certain app. And the GPS tracks the maximum distance they've traveled in a day. And the metric that I showed you is the median of all of the maximum distances traveled in a given day for a group of people. And the way it's kind of controlled for how cities can be different from, say, rural areas is that they look at the change relative to where that geographic area typically was at a time before physical distancing and stay-at-home orders went into place. So, at the peak of that graph is 100% marker, which is like where that society or that state usually is. So it kind of is an internal control for New York, and presumably, and these data are available at the county level. So it's possible to say look at how it works for the Bronx versus Brooklyn, or for Manhattan. I've not yet seen those data, but they are out there, and a lot of this data that we're using are publicly available on GitHub. It's great that that these teams are making those data available.
Thanks, Dennis. A question from John Santelli. Going back to the first half of your talk, could you comment on the role of antibody or antigen testing in the public health response to COVID-19?
Well, it does seem like, I think it's been different, right? There was a lot of discussion and focus on testing early on in the crisis, at a time when it seemed as if when we were doing physical distancing and stay-at-home orders, where testing was mainly useful for helping to guide healthcare provision and use of PPE and putting patients in negative pressure rooms. It was important to understand whether or not healthcare workers were dealing with a COVID patient or not, because it really changed how they would manage it. But not so much for the general population. I think that the idea was that people should assume that they were exposed, and if they developed illness, they should assume that they're infected and isolate, and come to medical care if they're in need of emergency medical care, and at that point they would get a test. But now we're moving into a different phase of the response, and I think the role of testing in the public health response is much different. We're hearing everyone talk about more testing, expanded testing, and using that information to isolate people who are testing positive and contact trace their contacts so that they can quarantine and maybe also be tested. There's also discussion about the need to have routine testing as a part of returning to work in many places. So it does seem like it's increasingly going to be part of the public health response, and an important part of it. And we are not in a place where we can scale it yet, any part of this, but it does seem like that's a prerequisite to reopening society, that we need to get to.
Thanks, Dennis. A question from Gina Wingood. Are you interested in examining the potential impact of influenza when that season approaches on COVID pandemic?
That's a really interesting question. They practically overlapped in New York. Like the upswing of this pandemic in New York, you could see it on the city health department syndromic surveillance slides that I presented. The upswing of this pandemic really happened at the downswing of the flu, the flu season here in New York, and there's potential for them to overlap. Yeah, I mean, I think this is something that we would. It's not up to us if we're going to be able to study that, right? It's going to happen, and we're going to have to deal with it. I'm thinking it's going to make things really hard, especially if we're not, able to get testing data and we're having to rely on people's symptoms and stuff, self-report. But we're going to have to.
Great. We have a question from Bob.
Yeah, thanks, Stephen. Thanks, Dennis. This is just so interesting and fascinating. I also want to just remind everyone, just feel free to just drop your name in the chat, or if you're on the phone and you are not seeing the chat, also feel free to just unmute yourself and ask a question, because it's great that we have all this time for discussion. So I don't want anyone to be shy about that. So even if you can't do it through the chat, just chime in and ask your question. Dennis, there is diversity in your cohort, but I was struck by, I mean, look, all of us are so aware of the disparities in this pandemic and the super high rates among Black and Hispanic populations, given the proportion of the population. So I think, if I remember, it was like around 25% of Black and Hispanic. So, which is, just if you can comment on that, it's not fully representative of who's really being affected by this, not only in New York, but across the country. So any thoughts about that? And also, is this a closed cohort at this point, or I wasn't clear, or are you still bringing new people into the cohort?
Yeah, it's closed at this point. And yes, we do have about 25% of our cohort is non-Hispanic, Black, or Hispanic. I think, I agree. We have seen like horrible disparities play out in New York City and elsewhere. I think this is something that is, reflective of the same phenomenon that drives disparities for other outcomes that we see, but it's been so vivid and rapid as part of this current crisis. And I think that it highlights the importance of the need to have strategies for managing the public health response to this pandemic that is, looking out for everybody, especially the essential workers. I think a lot of this is about, people who can't stay at home, people who can't isolate when they become ill with symptoms. And we need strategies to help prevent this kind of thing from happening in the next pandemic. And I hope that our cohort, again, not certainly not representative, but I do hope that we'll be able to shed some light on things that could work in the future, to gain some insights about what didn't go well and what could go better in the future. I think we'll be able to describe some of the longer term sequela of this epidemic and this pandemic by race, ethnicity, and I'm thinking about some of the economic and mental health outcomes. I do expect that those are going to be, in addition to the direct effects of COVID-19 that are differential by race, ethnicity, and socioeconomic status. I think those are going to in turn drive increased rates and disparities in mental health outcomes. That the job loss, the economic loss, and the direct trauma from being highly affected by the pandemic is going to drive a lot of other long-term outcomes that I hope that we'll be in a position to understand and highlight.
Okay, thank you.
We have a question from Phil Kroniski. While you noted you will not be able to look at state level data, I wonder if you could potentially make comparisons between high mobility and low mobility areas in terms of infection rates or other metrics?
Yeah, thanks. So that is something that the cohort is positioned to do. So we will be able to group areas that are similar with regard to certain characteristics that we are interested in. And for example, some states were faster at implementing stay-at-home orders relative to where they were in their epidemic than others, and we will want to compare the cumulative incidence in those situations and talk about the importance and how important it is to be even a few days or a week earlier and timing these public health responses in pandemic situations. And we also will want to compare the outcomes after reopening and in settings that use different strategies, maybe some that are guided by a priori stated metrics and others that are guided by ideology, for lack of a better word. So yeah, we do expect to do those kinds of comparisons that lump states together, but it's going to be very hard for us to do state-specific analyses given the sample sizes.
Thanks, Dennis. A question from Nadia Nguyen. You mentioned that you're currently still seeking funding for this study. Are these participants currently being paid for participating? And how is the adherence to the daily COVID tracking app?
So we did not offer an incentive to enroll in the cohort. But we have offered incentives for people to participate in the follow-up visits of the cohort. And so there's one incentive to complete the questionnaire. There's another incentive to complete the specimen collection. It's $10 and $20 respectively. And so yes, there's some incentives. As for the COVID symptom tracker, we don't know yet. We've only just started the follow-up last week, and which is when we asked our participants to download the app and affiliate themselves with our cohort in the app. It's completely voluntary, so I don't know what it will be, but there have been some anecdotal reports, participants reaching out to us saying, things like they couldn't find the app in the Android store, so it suggests they're looking for it, or other participants already downloaded the app and were using it before they enrolled in our cohort and now wanting to affiliate with the cohort. So we know people are trying to do it. I don't know what the uptake is yet. I don't expect it's going to be super high, but I think it's an important proof of concept because to be able to, we were not in a position to develop an app that people could use on a daily basis. And if other people were developing a good app, why should we develop our own app? So if it's possible to take some of these things and deploy them in your cohort to help you get the information you need without having to develop it yourself, I think it's worth exploring. And so I think at a minimum, we'll be able to get a sense of how we could deploy this thing better going forward so that we get more uptake in the cohort.
Thanks, Dennis. A question from Brian Kuttner. First, a comment. This is such an impressive endeavor, and you got it up and running so quickly. I can't recall if DBS collection has already started. Have you got a sense of how many participants are completing DBS samples?
Yeah, so last time I looked, we had about 1,500 or so people responding to the follow-up assessment. more than 90% had consented to the DBS, but it was not by any means all participants. So, but it's a very high percentage. I think it reflects, the demand for testing that's out there.
If anyone else has any questions, please enter them in the chat. And also, as Bob mentioned, if you're calling in, please feel free to unmute yourself to ask your question. Like Ashley Jordan has their hand raised. Ashley, do you have a question?
Hi, I actually don't. I accidentally selected the raise hand function and don't know how to put my hand down, so I'm sorry.
No problem, no problem.
And while other people are thinking, I also invite you, Dennis, if given the range of questions and just things that maybe you didn't mention, if there's anything you'd like to comment or add, or while other people are still popping in, I think, with some more questions.
Well, yeah, I guess I'll just say, I mean, I think that what we're learning is that there is a role for longitudinal prospective cohort studies in this pandemic. I think that there are some other jurisdictions thinking about the same approach. So I think there's a lot to be learned, and maybe even for much longer term follow-up than we had initially been thinking. I mean, we were thinking about 6 months, but it's increasingly looking like this is going to be something that lasts quite a while. There may be vaccines and treatments rolling out over the course of the next year, and this would be something that we could examine in our cohort. I guess the other thing that I've been thinking of, we would have liked to enroll a lot more people in the cohort. We had initially thought about trying to enroll 20,000, but and we could have enrolled 20,000 people, but we were also thinking about the importance of serologic testing, and we had said to our participants that we didn't promise it, but we did say that we would be pursuing funding to support serologic testing in the cohort. And so while it wasn't promising anything to our participants, it did sort of set up an expectation that if we could get funding, they would be tested. And so we were being confronted with the costs of the antibody tests that are out there, and decided that we should cap our enrollment early at 7. We were aiming for 7,500. But I do think, in an ideal world where funding wasn't an obstacle, we'd have, maybe the number of participants. So we could say more in smaller geographic areas about what's going on. But we're limited by the funding that we don't yet have.
We have a follow-up question in regard to DBS collection. Can you please speak to, and this comes from Nadia and Win, can you please speak to any challenges you encountered with the DBS tests in the piloting phase? This is so interesting and has implications for concurrently measuring viral load and ART drug levels in HIV populations as well.
Yeah, so we didn't have any, we didn't do a lot of pilot testing. It was just a handful of people, but none of them reported any problems with the home collection kit. The lab that we work with has done a lot more of this, and they have also said to us that something like 98% of the kits they send out, they get back, with adequate specimen and no issues. We would have liked to roll this out with a video guiding our participants about how to do a dried blood spot collection, but we didn't have time for that. I know a lot of other investigators do use that approach, and so if we had time, we would probably make a video. But we didn't, and we haven't gotten any people reaching out to us having problems with their kit yet, but they've only just started being received over the weekend, over this past weekend, by our participants. So it could be that we'll learn about more issues as more of them get received and used.
Thanks, Dennis. Nadia also asks, if you secure funding for serological tests, have you thought about whether you will share the results of these tests? My understanding is that some of the better tests are currently only for research settings versus those that are FDA approved for the public.
Yeah, we intend to share the results of our tests with participants for sure. And this is yeah, this I think is essential. I also think this is opening up another important area of inquiry around like implementation. So, you know, we've talked about how important it is for the public health response going forward to scale up testing and contact tracing, and there's not much talk about at-home testing as part of the public health response, but I do think, you know, what we're doing is proof of concept that it could be done. Well, hopefully we'll provide some useful information about whether it can be done. I think it will. And then, you know, I think it opens up an opportunity to understand what some scalable strategies for at-home testing might be. The at-home testing part is important not just for convenience, but because in many places it's not safe to go out to a healthcare provider or to a pharmacy or what have you to get a test. And so if we can figure out scalable and affordable and effective ways of getting tests to people at home, then I think we might have another tool to help scale up testing and contact tracing that we don't currently have.
Thanks, Dennis. Question from Brian Kuttner. Related to the psychological distress you're assessing, will you have a chance to assess how many people are in mental health care or subsequently seeking care, how they're accessing it, and what they're receiving? This seems pertinent to the general population, but also related to Goal 3 for healthcare workers in high incidence contexts.
We will have an opportunity to assess those things, and we already do assess the extent to which people have been have had a prior diagnosis of a depressive or anxiety disorder from a provider, and we could ask questions along the lines of what you're getting at.
If there are any other questions, please enter them in the chat.
Or just speak up if unmute yourself and just ask your question. It's been such a great discussion, Dennis. We're so appreciative.
Well, I'm glad the timing worked. Yeah, I was going to come back and do my presentation on HIV metrics, which would have been great, but then Theo asked if I had another talk, so I thought of this one.
Well, yeah, clearly this is of interest to this audience, and as I said, I think any follow-up you can provide with us, either through this Grand Rounds connection or through other kind of seminars or whatever it is we can do. This is going to be going on for a while. And it's so relevant, of course, those of us in the HIV field. I mean, it's another infectious disease. A lot of lessons learned from all of our years in the work in the HIV epidemic. I think a lot of us are just interested in the similarities, the differences, the lessons learned for both epidemics, for both pandemics, as we move forward. And again, the highlight for our most vulnerable populations and those being affected. these epidemics.
Yeah, I mean, I think, you know, so much of our experience and perspective working on another pandemic, the HIV pandemic, has been really helpful and instrumental to inform, you know, how we're approaching this. I was thinking a lot about the early history cohort studies that were done in the HIV epidemic to really just begin to understand what was going on in terms of prevalence and correlates and natural history of infection and disease. It's a lot of the same strategies here, but it's a very different disease and different mode of spread and things like that.
Yeah. But still, I think some of the same social determinants of health, right? And who's affected by these things. And that will come out of your data as well. So that's great.
A question from Nadia. As serological testing becomes more available, are you concerned about how the public uses this information, given that we don't actually know what the results mean in terms of risk of transmission or reinfection?
Yeah, I think the messaging around reporting serologic testing results back to people has to be, you know, very carefully scripted and communicated. I do think it's an open question at this point, one that we and others are trying to shed some light on about the short or long-term protective effects of antibodies to the infection. We don't know for sure yet, and we need to make sure that people who get these results understand that.
Thanks, Dennis. A question from Justin Knox. Great talk, Dennis. What opportunities do you think there are for trainees or early stage investigators to get involved in COVID research? Do you have any suggestions on ways to do that?
Yeah, I mean, I think, well, I think there's a lot of publicly available data out there that is not being fully leveraged. We will be making our data publicly available over the course of the next month or so, you know, a public use version of our data that early stage investigators can use, that we hope they do, and, you know, use it to do analyses and write papers and stuff like that. And I think there's all kinds of opportunities for our grant proposals that kind of answer some of the, maybe not the most urgent questions, but ones that are important to answer over the next year or two, that I think early stage investigators can take advantage of. I know that I mean, it's very competitive, these supplement requests that NIH has put out there, but it's possible to do a supplement request off of a K, and so that's another opportunity as well.
Thanks, Dennis.
Oh, and one other thought. I mean, we recently were submitting another grant, initially unrelated to COVID, but as we were writing, you know, and it was a mental health related project. As we were writing it, the whole COVID-19 thing unfolded, and we realized that that it was going to have a pretty long-lasting impact on the mental health of people in this city and in this country, and thought it was important to write it in and reflect that in the grant proposal. So some of it was completely re-engineered to learn more about how this pandemic and the response to the pandemic might have impacts on people's mental health and well-being. So it seems to me like every research project and every grant proposal, there may be opportunities to learn important new information about the response to the epidemic.
Yeah, I mean, I agree with that. I just want to add to that. I think, particularly across a center like ours and our collaborations with our CFAR, that, and particularly I think for our fellows and early stage investigators for all of us to be thinking about, as some of our other research studies that have been put on hold, or might be moving virtually for virtual assessments or ultimately opening up, to all be thinking about ways of studying or asking questions around COVID. Um, Back to Claude's question and comment earlier, that we should all be thinking about that and maybe sharing our measures, and so that there'll be comparisons across different cohorts. So I encourage particularly our fellows and early stage investigators to be thinking about that and talking with the various teams and the various ongoing research studies that we have in the HIV Center. And, across these cores and with Denis at the head of the ISHO core, we can all be thinking about that and sharing ideas for ways of assessing things as we move forward, as research opens up.
Dennis, I'm getting a few requests for your slides. Are they available to share?
Not yet, no. But I should have said that a lot of what I've presented in the slides are in our baseline paper, which is out on medRxiv. So if you type in my name into the medRxiv search, you'll be able to see our article, which has a lot of what I presented in here.
Thanks, Dennis.
Hey, this is Phil Kroniski again. I was just wondering if you could put on a slightly different hat and maybe like think about for research and for the next 6 months to a year what you think this might look like going forward in general.
The pandemic or the
Yeah, I mean, I
stuff?
understand that's kind of a broader and difficult question, but thinking about, if we're writing proposals to collect data, for example, are we going to be able to do that in person? Maybe, I mean, I would say probably not, but yeah.
Yeah, I mean, I do think it changes a lot of what all of us do as researchers. I think, I mean, there are so many things and so many unknowns. We're not even sure if we're going to be having in-person classes at our school of public health, or if they're going to be, some in person and most online. Whether our research teams are going to be able to come together in person, and even whether or not, the extent to which community-based organizations are going to be open with business as usual, and whether or not clients are going to be going to them to get the services they usually get. So I think it's going to be a whole different landscape, and I, what to expect in New York. I really don't know. A lot of it is going to hinge on the extent to which testing can be available and scaled. A lot of it will hinge on what we can learn about the protective effects of antibodies. And a lot of it will hinge on, I think, the extent to which technology can be leveraged to achieve some of these important goals of the public health response, to scale testing and contact tracing. It's I found, I mean, I'll just say that I found that every time I thought I understood what was going to happen next with this pandemic, starting in February, I was surprised, a lot of the time. So I don't want to speculate, Phil, beyond that.
Well, and also to maybe stating some of the obvious, but I mean, this is such an evolving thing, as Dennis just said, right? And I think, encourage us all to think about that, since we are all HIV researchers and care providers. Thinking about how we can really be understanding moving forward and looking at and studying the impact on HIV care as well as our HIV research. We're seeing a lot of nimble changing. IAPAC had a mini conference yesterday. We heard from people in the U.S., but also in African settings, changes that are happening in terms of people's access to care. We are seeing that routine access to HIV care has been disrupted. What's going to be the long-term impact on adherence, on viral suppression? Similarly with PrEP, I think that's a fascinating area of study in this pandemic because, first of all, are people, what physical distancing is and isn't happening? When things open up, what's going to be the impact on sexual behavior? As I mentioned earlier, HIV testing, use of PrEP. So there's a lot of things for those of us already doing HIV research to be studying, given the impact of this pandemic.
Yeah, I think something that's come out during all this is the importance and increasing role of telemedicine and in a pandemic, and maybe that will open up, maybe that will stick after a pandemic as well. It does seem something that's possible, something that may be a better way for some people living with HIV, for example, to be able to engage in care.
Yeah, including mental health care and screening and mental health care. And as I commented in the presentation I did yesterday, I think we look at the downside, but we have to look at innovations and opportunities for moving forward. So how can things be advanced? Not doing things the usual way. I think when we struggle with the lack of integration of behavioral health care or mental health care into primary care, and particularly HIV primary care. Sometimes that's because of physical spacing, where someone gets primary care in one location and they're referred to mental health care in another location, and it doesn't happen. Maybe through telemedicine, the integration, we can think about how that can happen more readily and more efficiently.
Yeah, agree.
And also, of course, being mindful of potential disparities in access to telehealth or telemedicine, we're talking about as well. So, Stephen, I don't know if you have anything else to say. I don't think there are any more questions in the chat.
Nope. I'll turn it back to you for any closing remarks.
Yeah, we're coming upon the hour. So I'm glad that we had that time for a discussion and Q&A. Denis, thank you again for just a fantastic talk and a very timely talk. Congratulations to you and your team. We're glad to be part of it as colleagues with you. And thanks for doing this. We look for updates, and thanks everyone for being here. And everyone, stay safe, stay healthy, and we wish you all the best.
Thanks, Bob. Thanks for having me.
Yeah, thanks.
Talk, Denis. Congratulations. Wonderful.
Thanks. Have a great day, everyone.
Okay. Bye.